computer, and she wrote
Okay.
direct for me.
All right, we are going to get started. All right. Thank you for coming. We have overflow, standing room only here in Hillcrest. Online, traffic is slow, so too many people log on. Just kidding. It's nice that you're here, and I hope to answer a couple questions you may have, even though I have no idea what your questions are. But I find that just showing up, you hear stuff that's like, okay, you know, and I don't know that this is going to be real practical from an inpatient management, but, you know, I work inpatient and outpatient, and the things that concern me are concerning me both here and across the street. So.
Just in the month, yeah.
Yeah. So there are a lot of hot topics in a year. You're talking about hot topics, and I think that this is what comes to my mind. PrEP is a big deal this year, or the last 5 years, really. There's new agents, new targets that they're working on. HIV and aging, that is where the research is. More than 50% of people living with HIV are over the age of 50. HIV inflammation, of course, inflammation is underlying the pathophysiology of a lot of disease states, and certainly in HIV as well. And then cure research, that's been, you know, there's never been as much cure research as well. So this is a brief outline, but I have a lot of slides, but I don't think I'll spend a lot of time on all my slides, so we will get going. And I like this slide from way back in '96 from this article. Doug Richmond's here and Diane Havler was here. Now she's in San Francisco. But HIV infection is a productive infection characterized by rapid turnover of virions. They estimate 10 billion particles produced, destroyed each day. Each virus lives about 6 hours. Total body burden of HIV turns over every 2 days. And so plasma replication or virus represents active replication in lympho-reticular tissues. The error-prone nature of reverse transcriptase allows for rapid mutations in the HIV genome, and they think that drug-resistant virions are present at baseline. And so inadequate drug therapy only selects for mutants that are already there. In other words, one drug may suppress wild-type virus, but the selected drug virus that's already resistant to that drug would then emerge as the predominant population. So I was on rotation as a fourth-year student when AZT got approved, and that started the sequential nucleoside therapy era. And then in the early to mid-90s, they found that 2 nukes were better than 1, be it AZT plus DDI or AZT plus DDC, causing a significant delay to the time of first AIDS-defining illness. And then in the mid-90s, 2 nukes plus indinavir, so that's when you had HAART, highly active antiretroviral therapy. Ritonavir was given full dose to some patients. And then nelfinavir in '97 came out on expanded access. The first NNRTI nevirapine. The first co-formulated was Combivir and then efavirenz in the late 90s. And so one drug is better than no drug. That's how AZT got approved. But what they found was that CD4 count rose for a couple months, and then by 6 months had gotten back towards baseline. But if you can imagine a CD4 count decline over time, and then people have advanced disease, getting AIDS infections or dying, if you intervene for just 6 months with a brief uptick, then you start that same decline because one drug's not working. In 6 months, people start having more age-related events. But 2 drugs, like in the early 90s, were better than 1 drug. But then with triple therapy, you finally had potent viral suppression. So then in the 2000s, there was definitely movement away from AZT and D14, DDI, you know, the D drugs because of toxicities, twice daily dosing. And you'll see there that tenofovir came out in like 2001, the first co-formulated boosted PI Kaletra, co-formulated Epsicom, and then Atripla is the first single tablet regimen. And then once daily regimens with atazanavir, the first once daily and boosted PI, although it's pretty much always given boosted. And then that most protease inhibitors could be dosed once daily with ritonavir boosting, and that lower doses would work with ritonavir. And then second generations, like in the mid-2000s. So tipranavir was the first second generation, then darunavir. So these drugs have activity against virus resistant to the first generation drugs. Likewise with etravirine, second generation NNRTI worked against virus depending on what the mutations were. But if people failed efavirenz, which was the most popular and always has been the most popular first generation, it would work against those. And then new targets, so enfuvirtide or T20 and maraviroc as two entry inhibitors, different mechanisms. I'll mention that briefly later. And the first integrase inhibitor, raltegravir or Icentris. And then also in that time, the mid to late 2000s, nucleoside sparing regimens, because people who came out of the 1990s who had severe neuropathy or back or hypersensitivity reaction, they didn't have good options. So then there was brief, period of dual therapy without nukes. And then the fact that Truvada with raltegravir was an option for treatment-naive patients, that was really helpful for patients. And then Truvada plus maraviroc got our FDA approval as first-line therapy. And then earlier initiation of treatment. So, and certainly now it's hit hard, hit early, if you will. Basically, when patients are found to be positive, there's a strong effort to get them on treatment, not just to get them, with their virus suppressed, but if they are, then they're less likely to transmit. So it's a big public health thing as well. And then since maybe 2011 to the present, there's a lot of single tablet regimens that archive DNA testing for doing genotypes basically when people have undetectable viral loads. Regimen simplification, that's a lot of what we do. And then pre-exposure prophylaxis or PrEP, and then the test and treat, which I just mentioned. So there are the drugs in the years that they were approved, so moving right along. So here's just a table to then show you, what's the components of a drug like Atripla or Triumeq, And I think everyone sees these drugs. You're familiar with these. Fortunately, our patients are throughout the hospital, so you all have a chance to touch them. But coming soon, Descovy or tenofovir alafenamide with emtricitabine and bictegravir, which I'll talk about later. And then the first PI-based single-tablet regimen, again, Descovy with Prescobix, if you will. And so both of these should be early in 2018. So combination antiretroviral therapy, or CART, has replaced HART because combination therapy is highly active, right? So basically, it's still 2 nukes plus something else, so one of those. And then if we look at the recommended regimens, a couple more slides, you'll see that it's really favors the integrase inhibitors. But these are the drugs that we still kind of see in clinic. We have some people who are highly treatment experienced who are on 4-class regimens. There's still a couple of people on enfuvirtide or T20. But there are problems with nucleosides, as alluded to early on in that history slide. But this year they are going to stop marketing the D drugs. So they have seen their time. So the mitochondrial toxicity, they don't have a good potency. There's really no need for those drugs, okay? There's more drugs are available. So this is just copied and pasted from the guidelines, and this table hasn't changed for a few years. Basically, the nucleoside backbone is either Truvada or Descovy. The difference here is the TAF form of tenofovir in the Descovy, with either an integrase inhibitor or the boosted protease inhibitor darunavir, ritonavir, or darunavir with cobicistat. And so then these are the agents that you'll see commonly in clinic. And these drugs are combined to make it on that list of recommended regimens. So there are some new agents. And this is a table I made. So the bolded drugs, I'm going to have more to say. I'm going to talk about the drugs that aren't bolded briefly. So ivolizumab is a monoclonal antibody, and a lot of data on these drugs that are not bold. Well, all these drugs actually were reported at CROI, the largest international HIV conference, happens every winter. So ivolizumab is a monoclonal antibody. It binds to the second domain of the CD4 molecule to prevent HIV entry. It works against both CCR5 and X4 tropovirus. And it's given by IV infusion. And in this small phase 3 study that was for 24 weeks, 40 patients who had at least 3-class resistance, some patients had 4-class resistance, they had to be able to add one new drug that had full activity. And then that was given with an optimized background. Then they received infusion of avolizumab. And there was about a mean 1 log reduction in viral load at 14 days, and only 43% of patients were able to achieve viral load less than 50 copies. And 9 of the 17 patients had severe adverse effects from the infusion, and 9 of the patients stopped prematurely. And there were 4 deaths that were not drug-related, but advanced disease, Kaposi sarcoma, a couple lost to follow-up, so small scale. But there was a bit of excitement because it was a new class that had, objective activity against HIV. Pro-140 and UB421 are 2 other monoclonal antibodies. Pro-140 binds to CCR5 and blocks entry of R5 tropic virus, given by weekly sub-Q injections. And patients who were on suppressive oral combination therapy were switched to sub-Q injections of Pro-140. And 10 of the 16 on long-term follow-up remained suppressed. And 9 patients for more than 105 weeks with just sub-Q injections as maintenance therapy. And there are a few adverse effects. UB421 binds to the first domain of the CD4 molecule, and patients on suppressive oral therapy were switched to maintenance therapy with this compound, given as weekly or every other week infusions for 8 infusions. And all patients remained suppressed during the study period or after restarting oral therapy. So, a strategy of just the monoclonal antibody infusion with no oral therapy. So they're looking at new strategies to treat patients. GS9131 is a nucleotide rich transcriptase inhibitor by Gilead, who has Truvada and tenofovir. And this drug has activity against virus resistant to all the current nucleosides. Has a high barrier to resistance, a long half-life. It's predicted, but there's no human data yet. I think it's getting closer to human studies. And then the capsid inhibitor, the capsid coats the genetic material as it's being assembled, sits under the viral envelope protein, and the capsid is important in several steps in the life cycle. The slides showing the mechanism was quite complicated, but a very potent agent, I guess on the picomolar range. Long half-life in rats, a sub-Q injection showed the drug lasted for at least 10 weeks, but there's no human data yet. And finally, the GS for Gilead Sciences PI1 is a novel potent protease inhibitor with a high barrier to resistance, active against virus resistant to atazanavir and darunavir, which is a second-generation PI. Potential for unboosted once-daily dosing. And then I didn't include on here maturation inhibitors, but if you remember the life cycle, near the end, before the virus is budding off, after proteases cleave the large polyproteins into smaller proteins as they're assembled, as the virus is maturing, there are maturation inhibitors. And so GSK bought Bristol Myers Squibb HIV portfolio, but they had to halt development of the first maturation inhibitor in October 2016, but there's 2 more candidate compounds coming behind. So fostemsavir is a HIV-1 entry inhibitor. It's an attachment inhibitor, and it's a prodrug of temsavir, the active agent. It binds to the viral envelope GP120, which I'll show you a slide of, and it interferes with virus attachment to the host CD4 receptor. Has a relatively short half-life, but it looks like the half-life is extended if you boost it or don't boost it with ritonavir, out to 7 to 14 hours when given in the ER formulation. It's metabolized by hydrolysis and CYP450 enzymes. They have seen some resistance in the GP120 protein with less binding. The dose that's going forward in phase 3 studies is 600 milligrams twice daily. There are some side effects listed here, but they were mild and well tolerated. And it's not an inducer of these CYP system. No dose adjustments are needed with rifabutin, etravirine, or boosted PIs. But it is a substrate of PGP, so it's susceptible to induction by rifampin. This shows in red HIV binding to CD4 receptor. See the little nub on that 4th little circle? That's the CD4 receptor, the binding site. There's a conformational change which exposes those co-receptors in the surface of the T cell, indicated by CCR4 there. And the complex rolls over, and then the final step is fusion, and the GP41 harpoons into the cell surface and pulls the two membranes together. And then Fuvertide actually gets in there and blocks that supercoiling together. And then finally you have the genetic material that can then enter inside the T cell. So fostemsavir or temsavir binds GP41 before it approaches the CD4 receptor, causing a conformational change, thereby preventing the binding of the GP120 protein to the CD4 receptor. Doravirine is a novel NNRTI, non-nucleoside reverse transcriptase inhibitor, with activity against virus resistant to the current available NNRTIs. And again, these drugs bind to an active site in reverse transcriptase to prevent reverse transcription. The half-life is around 11, 12 to 14 hours, and metabolism is by 3A4, and it's a substrate of PGP. They have identified resistance to it, but when given against virus resistant to the first-generation drugs, it maintains activity against K103N, Y181C, or viruses with both of those mutations, with no viral breakthrough. And the dose going forward is 100 milligrams daily. There are some CNS side effects, 27%, but certainly less than what you see with the efavirenz. The overall rate of side effects were reported at 32% versus 56% for efavirenz for drug-related side effects. And they are listed there. They're generally mild and is not an inducer or inhibitor of the CUIP450 system, but again is susceptible to rifampin induction and even rifabutin induction, but there may be a way to increase the dose, and that still has to be worked out. And it looks like it's susceptible to 3A4 inhibition by ritonavir. And this is just a headline of an article. This study then showed the drug had activity against resistant virus to the first generation agents. And so this was studied in I believe this is a phase 3 study, where doravirine and Truvada, or Epsicom, was compared to darunavir with either nucleoside backbone in treatment-naive patients in this format. So randomized to either arm, and then endpoint out to 48 weeks and then 96 weeks looking at patients undetectable on the viral loads. And so doravirine was non-inferior to what you would consider a standard recommended regimen based on DHHS guidelines at 48 weeks. And the nucleoside backbone did not matter. And side effects, it was well tolerated in general compared to darunavir or ritonavir. And I think what I wanted to point out here is it has a favorable lipid profile. And you can see that LDL is reduced compared to baseline. So across the board, it looks like it's a drug that has promise. I could see us having a role for it in clinic at some point. Bictegravir is an integrase inhibitor that's going to be appropriate for once daily dosing without boosting. And again, integrase inhibitors block the transfer into the nucleus where it's integrated into the host genome. Bictegravir has about an 18-hour half-life, has a high barrier to resistance. The mutations that are seen in vitro are listed for you there. And in a phase 2 study with Descovy, there were no integrase inhibitor or nucleoside resistance seen at 48 weeks. So it's being co-formulated with Descovy. The dose will be 50 milligrams once daily and can be given with or without food. It is well tolerated, and the most common side effect was diarrhea in the study, and there is some nausea as well. Voriconazole and darunavir ritonavir can increase the AUC 61 and 74% respectively. Atazanavir cobicistat increased the AUC fourfold, higher than what you would see with voriconazole or boosted darunavir. And then rifampin would reduce the AUC by 75%, so it is susceptible to inducers and inhibitors, and has similar caution as does raltegravir and dolutegravir with cation-containing antacids, so separate by at least 2 hours.
Is the barrier to resistance higher than
I'd say it's similar at this point, and there's the question was, is the barrier to resistance higher than what you see with dolutegravir? And I'm just thinking of it, I think Greg is as well, as similar to what we see with dolutegravir, which is definitely high barrier. And that means when patients receive this drug in clinical studies and there's viral rebound, then you do genotype testing on those isolates. When do you see resistance? And you rarely, actually, you don't see any resistance with dolutegravir. And they haven't seen it yet with bictegravir either.
So then, like the choice between the two, like what would you choose? Maybe you choose one versus the other.
Gilead just completed 4 phase 3 studies, and a couple of those were compared head-to-head with dolutegravir. So patients who are HLA B5701 positive who can't use abacavir, they can't use Triamec, this would be an integrase inhibitor-based single-tablet regimen. And we think that Triamec is in that it has dolutegravir, is in some patients a better choice than something like Genvoya, which has elbapixtomig as a first generation and a lower barrier to resistance, if patients are going to be suboptimally adherent. Any of us could take Genvoya, for instance, and we are going to have a great outcome. So, but we're just concerned about losing the integrase inhibitors. So, pharmacists are pretty good at predicting adherence, and it's been proven in a study we did 15 years ago. So, patient selection is important. Another advantage of this new co-formulated product will be tablet size is going to be a lot smaller than Triamec. And in the TOC office, Shannon has a model of these different tablets. And Triamec and BradColwellAtnitretroviralsClinical are like the 2 largest tablets. So it's going to be a lot smaller. That would be another advantage. And then there are some patients that have just ongoing GI upset with abacavir. So it's good to be able to interchange, so.
Question. So if a patient was on like elbapixtomig or a different integrase inhibitor with a lower barrier of resistance, are they still eligible for like say dolutegravir or bictegravir, or is it a class effect?
The question was if someone is doing well on a first generation integrase inhibitor containing regimen like Genvoya, would they be able to switch to a second generation regimen like Triamec or the new bictegravir? And the answer would be yes, because I think the way you asked the question was assuming they're undetectable. So, yeah, when you have no concerns for underlying drug resistance, so the viral load is undetectable, you can switch. And so there actually are a whole lot of data with these switch studies in patients on stable regimens with no underlying resistance, no history of viral rebound, who can switch to Stribild or Genvoya or these newer agents and maintain viral suppression. And this is an in vitro slide showing the full change of different resistant mutants to raltegravir in blue, elbapixtomig in orange, and then the second generation integrase inhibitors, dolutegravir in green, and bictegravir in yellow. How these 2 newer integrase inhibitors maintain activity against virus resistant to the first generation drugs. So it kind of depends on what those mutations are clinically, but this is just showing that bictegravir is at least as good in vitro as dolutegravir as far as expected activity. So again, this is a phase 2 study comparing bictegravir with Descovy versus dolutegravir versus Descovy in treatment-naive patients. It was a small study. It was reported at CROI in February. Just like 100 patients, 2-to-1 randomized to the bictegravir arm. And basically both arms had similar rates of viral suppression, similar rates of viral failure, no resistance documented on genotyping. Small numbers, but there was a higher number of side effects in the bictegravir arm. And so maybe you pay attention to this and say, I want to see the phase 3 data where there's hundreds of patients and see if these differences hold up. But pretty excited about this being available next year. And so here's just the press release from Gilead that they've completed, their phase 3 studies. And so they're getting ready to file their NDA. And so I don't want to go all the way back, but on my new drug slide, on the bottom, there were three strategies listed there, one of which was dolutegravir with rilpivirine as maintenance therapy. And so ViiV has filed, they just filed June 1st, and so by early December they should have an answer from the FDA if this is going to win approval. So again, patients who are on standard triple therapy, first or second regimen, but no history of resistance or viral rebound on stable regimens, then switch over to, well, here you go, dolutegravir plus rilpivirine, or continue the baseline therapy for 52 weeks, and then the control group switched over to the treatment arm as well. I believe the backbone could have been Epsicom, but 70% of patients were receiving tenofovir at baseline in their nucleoside backbone. So overall response rates were identical. And then it appeared to be safe as well. And so this just shows some bone markers that by going away from the tenofovir, if you will, there are improvements in some of the bone markers. And so if you think about some of the advantages of TAF, we think there's improved bone health as well as kidney safety going forward. So another strategy is, again, this induction maintenance strategy. So this study looked at patients who were on stable triple therapy who were then switched to dolutegravir plus just lamivudine in a maintenance therapy strategy going forward. And for 8 weeks, they replaced, for instance, the boosted PI with just the dolutegravir. And then after 8 weeks, if they were undetectable, they dropped the other nucleoside drug and continued just dolutegravir with lamivudine or 3-TC. And this was continued out for a total of 56 weeks. And so basically they had 97% of patients maintaining viral suppression. And week by week, it was very high rates across the board. And so they'll be filing for FDA approval of a co-formulated dolutegravir lamivudine product going forward in the future as well. And now this has also been studied, it's not as far along, in treatment naives. So the first study looked at patients with baseline viral load under 100,000. They had 20 patients who received dolutegravir and just lamivudine. And there were a couple patients whose viral load was over 100,000 when they started treatment, but at screening they were under 100,000. But the day they started, they were over. And I don't have that data here, but they all did good with their viral load outcomes. So.
These dual therapies, are the doses the same as if they were in the triple therapy?
Yeah, thank you. So the question is, are the dosing the same as what you would see with triple therapy? So yes, dolutegravir is 50 milligrams daily. Lamivudine is 300 milligrams daily, and rilpivirine is the 50 milligrams daily.
Are they planning to potentially co-formulate the rilpivirine with dolutegravir?
Yeah, so that's the one that got filed for NDA on June 1st.
Oh.
Yeah, so again, that just shows that some patients may benefit from this product if they can't take their current regimen. And, it's a new paradigm. So I think that, Craig and I, we would like to see more data. And again, that last slide I had, just looking at drugs that are available in the last 8 years or so, we have really good single tablet options that are safe and well tolerated. So, and especially with TAF available now, there's, we feel really good about the treatments.
They have adherence data, like there's a break point in which at a certain number of missed doses, then you see viral rebound and resistance.
Haven't seen data like that. The question is, do they have accurate adherence data where you can chart how many missed doses may give you a poorer outcome? And haven't seen that. As far as how many pills per day, when you're getting that number down to 3 or 2 or 1, when do you see an improvement in adherence? And of course, 1 tablet daily is the best. Some studies show 1 or 2 tablets daily, once daily, are equal. There is a lot of adherence data out there, but I'm not up on it. I've seen a couple studies.
Especially for just the 2 drug regimens, it's like can you miss less? Is it that you have to miss less to keep your viral load undetectable versus a 3-drug regimen? It's not.
Yeah, I don't.
Robust.
It would depend on the regimen, because you can imagine a 3-drug regimen that's not contemporary, where the barrier to resistance is going to be lower, and something like dolutegravir or rilpivirine would actually have a higher barrier, you know. And it's, you know, that's the fun part of the job, is determining what's going on, what's really going on with the patient's virus, and what is the minimum amount of drug you need to keep their virus suppressed compared to someone else. Because we question people's adherence weekly, but maybe they're actually getting enough in to keep them suppressed. And I know that patients walk out of clinic, you know, knowing stuff that we don't know. Maybe they're taking 5 days per week instead of 7, and their viral load always remains undetectable, and they're fibbing us, telling us they're taking all of it. I did not include a study. It's one of my other recent talks, but there was a study looking at ATRIPLA, Monday through Friday, versus daily dosing. And they did it. They studied it because patients sometimes skip anyway, so they thought they should study it. And it showed that you could maintain viral suppression. But it would never be recommended because people start skipping Monday too, so then you're like on off, and that's bad. So, and that was a short-term 8-patient study. So, all right. So you all have seen TAF over the years. I know it's an interesting drug. So we have tenofovir up there in red. It is not absorbed. You need to make it a salt form. TDF, tenofovir disoproxil fumarate, is a salt form which allows the absorption of tenofovir, where it's rapidly cleaved in plasma. So you get high levels of tenofovir, which are then actually pumped into renal tubular cells. And there's still tenofovir that makes it into the CD4 cell where it works at the site of action. When you give tenofovir as TAF, tenofovir alafenamide, it's more stable in plasma. And so less drug is available for uptake into proximal renal tubular cells. Plasma levels are reduced by 90% when you give tenofovir as TAF. So that's Descovy or the Genvoya or the Odefsey. But there's still adequate tenofovir that makes it into the CD4 cell where cathepsin A cleaves it, and it can be diphosphorylated to active moiety, such that intracellular levels are 4 to 5-fold higher than what you get when you give tenofovir as Truvada or Stribilt. So we, as pharmacists, say, well, we want to use TAF because it's safer from a kidney standpoint, bone standpoint. Also at CROI, this study reported on 144-week outcomes. And so it did show, fortunately, that there was no tubulopathy with TAF-based therapy. And there were some small numbers with the Truvada or TDF-based arms. So, and then, again, less bone loss with the TAF. So, this was encouraging because although we thought early on it's going to be safer, now we have 3-year data that shows, hey, no tubulopathy. We think that's important. So
would you confidently assume that if the patient was on a TAF regimen and they did have a bump in their creatinine, that it would not be from TAF?
The question is, would you be more confident assessing a bump in creatinine if someone was on a TAF-based regimen that the bump was not necessarily from the Truvada or tenofovir, I should say tenofovir or TAF, in the regimen? And I think yes, because that person has probably already been on TAF for a while. Let me just point out that cobicistat impairs the secretion of creatinine, so you always get a bump when you first start both cobicistat-containing regimens and dolutegravir-containing regimens, which block OCT2. I think with the aging population, with hypertension and diabetes, there's other factors that can lead us more towards a bump in creatinine when you see a tenofovir-containing regimen. And our nephrology friends, we get them referred back to us, and they still want to remove the tenofovir, meaning the TAF form, from regimens, and we're not really convinced that that's contributing at all. And in certain patients where we feel that's an important drug to maintain viral suppression, it's, we haven't always gone along with that. So what's a day in clinic like, or a day in the hospital like, when patients get admitted? We're dealing with breaks in therapy or regimen simplification. If it's an outpatient, they lose insurance, or they lose their drugs, or they relapsed on meth. And those are often reasons why they come in the hospital too. Regimen simplification, we still do a lot of that. You know, you guys have seen that. So anyways, that's what makes the job fun, is just working with patients to come up with the option going forward. So a lot of reasons for breaks in therapy. Certainly across the world where there's political conflict and already, you know, tenuous drug supply chains, you know, throw political conflict in and people are really at risk. But yeah, a lot of reasons why people can have a break in therapy. And yeah, polypharmacy is on the list. So regimen simplification can help patients. So we try and get a clear picture of the actual drug exposure when therapy has been interrupted. You know, what's the patient's pattern? We try and use the self-report adherence tools, try to narrow down the dates when they were actually supposedly on therapy, correlating it with their viral load time at the time of exposure. Check refill history of patients' pharmacy, pill counts, bring in all their drugs. You know, we take away drugs from them. And we just want to try and determine the likelihood of having them develop resistance. But the implications are the loss of virologic control can result in drug resistance and loss of future options. And if that happens, then the goals of therapy, which are listed here, you know, will not be achieved. And it's not just that, you know, they're going to have drug-resistant virus, but whenever you have viremia, there's a risk for non-age-related complications. So this is a very important study that's still quoted or referred to, the SMART trial. This was over 5,000 patients, and it was a strategy back in the early 90s to look at, you know, conserving drugs, if you will, compared to continuous therapy. The reason for conserving drugs is patients were taking drugs that had side effects, or they had large pill burdens that they couldn't adhere. And so they wanted to ask, is it better to stay on therapy continuously, or can you interrupt therapy when T cells got over 350, but resuming it when they got to 200 and keep it safe for patients? So going forward, they found that it was a really bad idea to interrupt therapy. And so the top left panel shows a statistically significant difference between the drug conservation arm versus continuous therapy. So in red, if you're interrupting therapy all the time or waiting to start therapy for the treatment-naive patients who came into the trial, waiting to start to go under 200, there was significant difference in the number of age-related events and death. And then bottom left shows that there were major cardiovascular, hepatic, and renal outcomes as well as a consequence of interrupting your therapy, having this rebound viremia, which increases inflammation, and this cascade that results in cardiovascular events or renal events. So very much not a good idea. Now, there are strategies when you think about pharmacology, and again, that's what's fun about being a pharmacist. If you're assessing someone's vanco levels, you know, you're running the PK, we're always trying to see what's going on. So the older drugs have discordant half-lives. And so the SMART trial used the strategy of, depending on the regimen, either simultaneously stopping the whole regimen, or if they thought that they had discordant half-lives, let's say they were on Combivir and nevirapine. Combivir, the two nukes have a very short half-life. Nevirapine is a non-nuke, a long half-life. If you simultaneously stop that, the nukes go away, then you have single agent with a low barrier to resistance. So what you would do is stop the nevirapine but continue the nukes for a week, allowing the drug level of the nevirapine to fall down. Then you stopped everything. So the SMART trial used a strategy of predicting half-lives and interrupting therapy. And so this just shows some of the curves that may be seen based on discordant half-lives. Okay? And so that first panel shows a large area of black where there's functional monotherapy. And there is a zone of resistance selection, which is the second row up from the bottom. And so there's a lot of time where you have monotherapy. Contrast that with the bottom right panel, where all three drugs have similarly matched half-lives. You stop all that at once. When the virus is seeing low drug levels, it's still seeing combination therapy. Combination therapy is not selective. It's not going to select for resistance. Yes, virus will rebound because there's not enough drug to suppress it, but it's more likely to be a pan-sensitive virus. Hopefully I didn't lose you. So anyways, they then looked at some of the resistance outcomes of this SMART trial. And this just was a trial to look, and again, these were people where they tried to stagger and stop based on half-life. So this showed that looking at non-nuke mutations, there were 17% overall patients who were on non-nuke containing regimens who developed drug resistance. But if patients were undetectable when they stopped their treatment, they were much less likely to develop drug resistance. And so I think that, there we go. Yeah, less likely when viral load was less than 50 at the time of interruption. So our message to patients is take this, never interrupt it. If you feel something's going on, you have to interrupt, call us so we can advise you. But it's best to stop all at once and not stagger your drugs, okay? Stop everything at once, and then we just hope there's no drug resistance. But when you look at the half-lives of currently available drugs that are used and are recommended in the guidelines, they are more similarly matched. So as composed to the older nukes on the very bottom, that's the serum and intracellular half-lives, listed there. So I think the single tablet regimens we have currently have better pharmacology, meaning the half-lives are more similarly matched. So when patients have breaks in therapy, there's always a question, what did they select for resistance? So drug resistance testing in this setting should be performed while the person is taking their drugs if possible, but if not, within 4 weeks of stopping. And I'm going to show you a slide why that is. If greater than 4 weeks have elapsed, it may be reasonable to do a resistance test depending what the regimen was they were last on, like a triplet-based regimen, which you can pick up the resistant mutation K103N and get some information there. So this study by Steve Deeks took patients who were failing combination therapy in stable regimens, and there was a control group that continued the failing regimen versus stopping completely. And then they did weekly measurements of viral load, T cell counts, and resistance testing to see the impact of stopping. So if you're taking a failing regimen, there's drug resistance, you can measure it on resistance testing. You still have a lot of virus that's being suppressed, wild-type virus. But when you stop the failing regimen, all this wild-type virus just repopulates rapidly and can cause harm. And this study showed that. So these are 4 different panels from individual patients showing in time, there is a point in time when you are unable to detect resistant virus. When that line falls down and becomes horizontal, that's when you're detecting wild-type virus, okay? Now, the principle is that resistance never goes away. You may not be able to detect it, but it's always there. There are technical limitations to the commercial genotype testing. You need to have 500 copies or more to do your test. Likewise, you need to have a virus population contributing about 10% or more of the virus population at the time of testing to be able to detect it. So if you have someone who's been off treatment for 3 months and you want to do a resistance test, chances are all you're going to see is wild-type virus. So it's not going to tell you much. All right? If someone stopped treatment and you're going to do a resistance test 2 weeks after stopping, this study would say that's probably reasonable. You're probably going to get some information. Okay. Likewise, the immunologic harm when the virus changes from a resistant strain, meaning the wild type has repopulated and become the dominant population, causes a rapid decline in the T cell count. So the top panel is the viral load, and that inflection point when it goes up is when the CD4 count that was stable on the bottom pane starts to fall down. So if you think back to that SMART trial, patients could have been doing good on combination therapy. Their T cells were rising, their viral load is undetectable, but because they were on the drug conservation arm, their T cells hit 350, it's time to stop treatment, then they're going to have eventually, within weeks, a rebound of viremia that's going to really harm their T cells. So that explains why there are events that were age-related events in that trial. So once a mutation's been selected, it's archived in the HIV reservoir and is likely to reappear under appropriate selective pressure, even if not detected on the most recent resistance test if it was done when you're not on treatment. So in patients who are virally suppressed, but you think they may have underlying resistance, maybe they're taking a 3-class regimen or 4 drugs, you may want to do this archive testing because you can then get an answer that may help you simplify a patient's regimen. So in these decision points, it's important to assess the adherence and tolerance to the current therapy, their response to treatment, their history and inner history of resistance testing, and try and track down old resistance tests. And we do that by calling outside providers and calling our lab in San Francisco. And also, if you're moving away from a regimen, if you're moving off of a tenofovir-containing regimen, make sure the hepatitis B status. Patients who are Hep B surface antigen positive are at risk of a flare. You don't want to cause a big hepatic event. So I'm going to present a case now, hopefully quickly, that I presented about a month ago for Owen Clinic, and I tried to really shorten it for you. But it was a real teaser. So a 57-year-old man with AIDS based on T cells under 200. His current T cell count was over 500. Viral load is not detectable. On a current regimen of Triamec and boosted darunavir twice daily. He was adherent and tolerating well. But he came to our clinic in January of 2016 to evaluate possible drug interaction with his current therapy and proposed treatment for AFib, although he wasn't sure which agent. But he knew that the cardiologist was concerned about his regimen. Okay, he has paroxysmal AFib, hypertension, obese. Currently was on sotalol, omeprazole, aspirin. All his chemistries, laboratory tests, urinalysis were normal at all time points for the purpose of this case. I tried in one slide to summarize his AFib treatment history. Was diagnosed in 2012 with paroxysmal AFib. Responded initially well to a low dose of metoprolol, but eventually had some fatigue, so they tried diltiazem, 120 milligrams daily. Less fatigue, but it wasn't effective for his AFib. He had, breakthrough episodes. Went back to metoprolol. The dose escalated to 75. Eventually had poor control. His episodes would occur at night from anywhere 1 to 2 hours to all night long, and they were happening 3 to 5 nights per week. So along the way, the cardiologist would comment about concerns about interactions. He was thinking about some drug, but the patient didn't know. He also talked about ablation, but the patient was not interested in that. So again, at the appointment with us in January, he was said that Dr. Krugman was concerned about his protease inhibitor. So we went to work. But so here's the classification of antiarrhythmics. So he was on sotalol at the time. Sotalol on this chart is a class 3 agent. Sometimes you see it as a class 2 agent. But can you pick a drug, audience participation, that Dr. Krugman may have been considering for our patient?
What's that?
Okay, so for an antiarrhythmic, yeah, for his AFib. Amiodarone. Anything else? Maybe dofetilide, right? Yeah. It's AFib that's progressing. He needs something better. So this is his treatment history. Bottom slide shows he was diagnosed in 93. And this table starts with some blanks, many years, like in the 90s, of unsure treatment. But when he came on our radar, he was on abacavir and stavudine and boosted sequinavir or Inverase and was failing that regimen. Eventually, the stavudine was replaced with tenofovir. So bottom right, he had resistance testing because he had detectable virus, showed 3-class resistance. And then in May of 2006, he entered a trial that was given raltegravir or placebo, and he added enfuvirtide T20, and he added in tipranavir, the new second-generation protease inhibitor. He achieved viral load suppression so that eventually he was able to use open-label raltegravir and get rid of the enfuvirtide. And it was actually Irina who saw him at this December 2014 visit who helped him. And then the darunavir was able to replace the tipranavir. And then further, and then her effort on that day was to give the Triamec and the boosted darunavir twice daily. So nice work. Here is his resistance test results and the Stanford HIV database interpretation. And again, at the time of testing, it was abacavir, stabidine, it was the sequinavir. So 3-class resistance. And I kind of cheated for you. In 2004, darunavir was not available, so it wasn't on that resistance test. But we can put those protease inhibitor mutations into the Stanford site and then get into prediction of darunavir activity. So I think I have a question for Nona, who just completed the rotation with us.
No.
What are your thoughts? What would you do?
Did you see the look on her face?
I know. I woke her up. But what would you do? What would you do? So someone who needs a regimen that doesn't include boosted protease inhibitor, we have 3-class resistance. If you remember his drug therapy, he's taking omeprazole. Shannon.
What's the omeprazole for?
It's for GERD. What's the omeprazole for? We think it's for GERD and not like ulcers, you know? Yeah. So that's always a question, do they need to stay on it? So this was Min, our resident from last year. Basically, this is his assessment from the progress note. The bottom line, he's identifying options. So with the K103N, rilpivirine would probably have activity. Rilpivirine is a 2nd generation NRTI. It's available in Odefsey or Complera. He recognized the interaction with omeprazole and asked the patient, and the patient said he'd be willing to try and stop it to see if he could get by without it. And if you were thinking about an archive test, which I was thinking as well, so again, his viral load is not detectable. We want to try and get all the information we can before we start altering a regimen that's working. So the cardinal principle from the guidelines of regimen switching is to maintain viral suppression without jeopardizing future treatment options. So there's a lot of reasons why you would consider, but for this patient, it was to address his drug interactions. And I think we were really careful with him. We had several visits. This is the GenoSure archive DNA test that came back. And it pretty much confirms the planned regimen of Complera and dolutegravir, that it would actually be a regimen that would maintain viral suppression. Okay. So again, this is a setting of someone who has immune reconstitution, his T cells are over 500, who's had years of viral suppression. It's different than someone who had 100 T cells, viral load 600,000 with all this resistance. We wouldn't feel comfortable with this type of regimen. I would just point out in yellow, near the bottom, the protease inhibitors, the darunavir is yellow, showing there's intermediate activity with darunavir. So fortunately, this guy takes his drugs. We know that raltegravir is a very active and important drug for him. I should say the dolutegravir in the current regimen and the raltegravir before that, but the integrase inhibitors are doing him a lot of work here. So if you remember talking about TAF, you achieve 4 to 5 fold higher intracellular concentrations of tenofovir when you give it as TAF. The reason antibiotics fail or are resistant is you can't achieve high enough levels to overcome the drug resistance. It's a similar concept with antiretrovirals. You're limited by what concentration you can achieve. This study I found a few months ago, and I said, Craig, look what I found. I think this is really going to be important. And even before this trial came up, we were wondering if we were going to be achieving higher concentrations intracellularly that would actually have activity against some of this resistance. The reason this study was important is it kind of confirmed that thought. So Gilead with Monogram, they developed a virus breakthrough assay with TAF exposure set at expected physiologic concentrations. And then they showed that HIV isolates or mutants that harbored tenofovir resistance mutations were able to be suppressed with concentrations of tenofovir that you can achieve with TAF. This is in vitro, but we think there's patients along the way right now who are getting some additional antiviral activity by giving TAF. Okay, so if I go back a slide or two, that tenofovir shows high-level resistance. And we know that if 41 with 3 TAMs, you really don't respond to tenofovir when you give it as TDF, the Truvada. Okay. So when I saw the patient in July, it was finally time to stop omeprazole and see how he did. And we were talking about a new regimen of Complair and dolutegravir. He came back then a month later with a prescription for dofetilide. So that's the drug. It's like, oh my gosh, now we know. And the cardiologist said, do not start until cleared by UCSD pharmacology providers. And arrangements made for admission. And it's like, oh my gosh, that sounds good. Pharmacology providers. So we don't call ourselves that, but we think ourselves as kind of providers. I'm like, we're managing therapy, but it's like, okay, I don't want to disappoint him, so. All right, so what would you do? Well, you'd have to then, okay, so he had DC to omeprazole, no reflux symptoms, so that's great. But we have to evaluate dofetilide for drug interactions, right? It's a new drug, and we don't see a lot of dofetilide. I think I really need to look into this drug. Has anybody seen dofetilide this year? Everyone's shaking their head online. So how do you manage drug interactions, right? This is just how I approach it. Well, when is it likely to occur? For the drug to be affected, how long have they been on it? Are they tolerating it? Doesn't apply with dofetilide. He hasn't started it yet. He's not in the dosing range. He hasn't started it. What about the toxicity? Yeah, what is it? Yeah, absolutely. QTC prolongation. So, and so is it dose related? What's the toxicity at higher doses or levels? Depending on the scenario, you would just proceed with monitoring. A lot of that goes on. Empiric dose reduction or stop and come up with an alternative. I didn't feel we had alternatives, but we just kept looking. I mean, like let me just go on. So yeah, it's a class 3 agent. You'll use more likely for supraventricular arrhythmias. Potassium channel blocker prolongs refractiveness. More potent and more pure class 3 agents than sotalol. It is eliminated by OCT2. Okay? And so this is a trial that was trying to look at pharmacokinetic and pharmacodynamic modeling of dofetilide concentrations and the effect on QT prolongation. Okay? 10 healthy volunteers received single IV and then randomized crossover to single oral doses as well in a crossover study. And then they analyzed QT prolongation in relation to concentrations. And the conclusion was that dofetilide does prolong QTC interval in a concentration-dependent manner. So half-life 10 hours, some 3A4 metabolism, but definitely cleared renally, and that's how you start the dose based on kidney function. But it's cleared by OCT2. And so the renal elimination is by filtration, but this active tubular secretion. So it's contraindicated with inhibitors of that renal cation transport inhibitors. So the interactive potential are of course 3A4 inhibitors, drugs that prolong QTC, so pharmacodynamic interactions, drugs actively secreted, so like emtricitabine is secreted. One of those drugs is going to win out at the expense of the others. If emtricitabine wins out, then dofetilide could rise. And then drugs that block OCT2. When you initiate dofetilide, patients get admitted, so you have continuous EKG monitoring. And you give the standard 500 microgram dose to start, and you monitor EKG 2 to 3 hours after your dose. And you just do this till you got them on a stable regimen. And based upon creatinine clearance at baseline, you either start at 500 twice daily or reduce it appropriately based on the kidney function. And then dolutegravir is a second generation. I just want to point out that on the bottom it is an inhibitor of OCT2 and potentially MATE1. So in our searching, we looked at CP Online and find that dofetilide and dolutegravir is contraindicated. Micromedics also identifies it as an important interaction. What about raltegravir? It's cleared by 1A1. It's susceptible to rifampin as a strong inducer, but there's no interaction with dofetilide. So are you thinking at this point that raltegravir would be a better choice than dolutegravir? Yes. There's no expected raltegravir resistance. The archive genotype in January showed none. It's an active drug. Just because it's first generation doesn't mean it's not a very good proven performing drug. Okay, and we're at a point where he needed dofetilide. What about rilpivirine? Rilpivirine is associated with QT prolongation in higher doses. The approved dose is 25 milligrams daily. 25, you would go to 50 milligrams if you're on rifabutin, but that's still less than 75. So although it's contraindicated, we ignored that and thought we had to give it because we needed active drugs for its HIV. And then caution with dofetilide and emtricitabine. So in August, we went ahead and made the switch to stop the current regimen of Triamec and boosted darunavir. We started Odefsey because in March, Odefsey was approved. Our discussions of Complera were, now we can use Odefsey. So we used the TAF form. He's feeling a little bit better about the activity of the regimen with raltegravir. October, he was admitted. He did fine on dofetilide and metoprolol 100 BID. In February this year, he was seen and he was having some ongoing episodes of AFib. And the most recent episode lasted 10 hours. And the patient was really getting concerned, is this being disruptive to his lifestyle, like to ride motorcycles, concerned for his safety. He finally chose to get ablation because he was concerned about the interactions with his ARBs, although we already took care of that. And his QTC was fine. Last April, with his PCP, he was responding well to this new regimen, adherent, tolerating it well. Vital signs were fine. EKG was fine. Still considering ablation. Don't know why he just won't get scheduled and get that done. So what do we do for inpatients? Are they on a regimen or you get the orders? Okay, well, does it make sense, right? Does it make sense? So these are just things you would look at. Are there just 2 agents? Hopefully I gave you a heads up that in a year or 2, maybe there will be people on just 2 agents, but it should be a single tablet. But, it may be right. And you can check with Shannon. You can call over to clinic. Are the doses right? Match that up with organ function. Okay. Any important drug interactions or dietary interactions? And questions, talk to Shannon or call over to clinic. And I meant to put a red line through my name, but I didn't because you can still call me in the next 3 weeks. Yeah. And actually, this is a picture from New Zealand, and I hope to make that my retirement trip, but it may be a few years. But that's the trip we're going to get the minivan and just, 4 to 6 weeks just traveling as a vagabond. So are there any questions, everybody? Here?
Most of you guys already do this, but since Brad talked about, what you're looking for if you're like admitting a new patient, if you have some of those red flags of like, something's weird about this regimen, or I think we're a long way off from it being normal to see only 2 meds on there, so you can always question those regimens that look odd, but you're welcome to, I'm always happy to look more into them, especially if you're on like an evening shift, you have time, I can always call the pharmacy in the morning, feel free to hand things off to me. It's like weird regimens, you're like, I don't know about this one,
And if anyone hasn't set up a filter when you're searching for like Coumadin clinic notes or endocrinology notes from Dr. Kalasa, I have a filter for all pharmacists, pharmacy residents, and students. And I click on that and I get your notes wherever you're at in any clinic but to get our notes as well. It's a direct, easy way to find our notes. There was an online question about, are any of the newer agents being used for PrEP? And I can say yes, there's nano formulations of rilpivirine and actually cabotegravir, which is pretty much just like dolutegravir, which is being studied for pre-exposure prophylaxis. Yeah. There's a rilpivirine vaginal ring that's been studied. Yeah, so they got very aggressive and creative with the PrEP type treatments. So. All right, thank you, everybody.